We now move ahead with the state-of-the-art lectures. We have 2 lectures for 13 minutes each, and then we'll take up 2 minutes for observations from the chair. May I invite our chairpersons, please welcome Drs. Amit Vora, IPS Kalra, Samir Srivastava, Amarpal Gulati, Aarti Lalchandani, Sandeep Mitra, Sarita Gulati, and Colonel S.K. Parashar. The first speaker is Professor P.C.Manoria, the past president of Cardiological Society of India and Director, Manoria Heart and Critical Care Hospital from Bhopal. Professor Manoria joins us to deliberate on dyslipidemia, flashback and vision ahead. Are we heading for another revolution after statin era? Professor Manoria, please. Thank you very much.
For the next 13 minutes, I'll be talking on dyslipidemia, flashback and vision ahead. And are we heading for another revolution after statin era? Research in dyslipidemia continues unabated, both in terms of enhanced understanding and in the availability of a rich panoply of therapeutic options and drugs, as you can see on the slide. But the breaking news is that 2 PCSK9 inhibitors, avalocumab and alirocumab, have been approved for clinical use. Avalocumab in Europe and alirocumab in the United States. Curiously enough, both these drugs have been approved without waiting for their ongoing outcome studies, that is the 4-year trial with avalocumab and the Odyssey outcome with alirocumab, perhaps because of their marked reduction to the extent of 40 to 60% in LDL on top of statins. The second very exciting news is, and therefore PCSK9 may be the next wonder drug after statins. I'll show you the data. And the next exciting news is the legacy effect of statins from the long-term follow-up WASCOV study. You take statins for 5 years and enjoy the legacy effect for 20 years following that. And the third very exciting development is we are now equipped with very powerful imaging techniques by which we can visualize the composition of the plaque and also assess serially the effect of various drugs on the plaque. You can clearly see this is vascular MRI. This is before statins, that is after statins. Statins delipidate the plaques, and all of us know if they delipidate the plaque, this is associated with better outcomes. And this is PET-CT, a hot plaque in the left main. It is true that these modalities cannot be employed in our day-to-day practice, but certainly the lessons learned can be utilized. Now, this shows the evolution of lipid guidelines during the last 27 years, ever since ATP1 came into existence. LDL has been the primary target for several years, and non-HDL cholesterol has been the secondary target for several years. But the ACC/AHA abandoned all targets in 2013 because at that time there was no non-statin therapy which could change the outcome of patients. For the last 1 to 2 years, several professional bodies have recommended non-HDL as the primary target for the reason that it encompasses all atherogenic lipoproteins, gives an idea of the number of atherogenic particles, which is a better predictor of atherogenic risk and is simple to calculate. There is some outcome data also. Doctor, you have already seen the last speaker. But the evidence for LDL lower is better is getting very, very strong due to recent data, and I'm sure the ACC is very likely to come with a focus update with a target for LDL. What is this data? After the ACC 2013, we had the Improve It, which clearly shows that if you combine ezetimibe with simvastatin, compared to simvastatin alone, there is an improvement in the outcome because combination had lower LDL levels. This is old data we already had from the Prove It 22. LDL was less than 40, yet the benefit was greater than the higher LDL. And this is the Jupiter trial where the baseline when it was 60, there was more benefit compared to higher LDL levels. And if you give statins at 60, rosuvastatin, the LDL which is expected to be achieved may be 30. Then we have the meta-analysis from the CTT which shows that even if you start statins with LDL basal level at 77, there is a 20% reduction in the cardiovascular event, and you can achieve 77, another 50% less will be somewhere 38. And PCSK9, I'll be showing you the slide, a 40 to 60% reduction on top of statins, LDL achieved 25 or so without any harmful effects. What about HDL cholesterol? All trials of HDL elevation on top of statins, be it NICE and be it NSAID inhibitors, have been flop trials, and at the present state of time, there is no evidence-based target for HDL cholesterol. HDL cholesterol, in fact, is a fallen angel. Triglycerides, you have already heard. There is no doubt we have data that higher triglycerides are associated with increased cardiovascular events, but there is no randomized controlled trial, a large one, to show that lowering of triglycerides is associated with decrease in the cardiovascular events. The Accord LLA trial was negative. The subgroup analysis did show benefit in the subset with HDL low and triglyceride more than 200, but this is only subgroup analysis. It seems that triglyceride has not been properly investigated in the Indian context, where triglyceride is a real problem. If a trial in this focus update is carried out, perhaps we may be able to get the data. This is the Ctt Meta-Analysis we were talking, but I'm not going to spend time. It's obvious. And this is the data from the two trials of PCSK9 inhibitor, the Odyssey long-term. You can see improvement in the cardiovascular events with very low LDL levels. And this is the Osler data. Again, both the curves are divergent. So LDL hypothesis is getting stronger and stronger. It's not possible to. This is the legacy effect of the statin in the Voskov trial. You can see even at the end of 20, 25 years, the curves are divergent except for stroke. The other question which is often debated, whether to use low dose or high dose, but if you are a patient of a cardiovascular disease or high risk, never say no to high dose statin, and this will be very clear in the next two slides. Now these are two landmark trials which use statin in the conventional doses, and you can see it takes 1.5 years for secondary prevention trials for the curves to diverge, which means you will be taking statin for 1.5 years without any benefit, zero benefit. But if you look at the primary prevention trials carefully, it takes 9 months for the curves to separate, clearly indicating you take 9 months statin for primary prevention with zero benefit. This is because the plaque burden is less. So what we should do, if you take high dose statins, you can very clearly see TNT, the curves start separating very early compared to the convention trial. So never say no to high dose statins in these high dose. This is the Jupiter data. If you use high dose, look at if your curve falls in this less than 50, your future is entirely different than when if it is more than 50. Another message for statin is you should not stop statin at the time of acute coronary event. If the patient was taking statin, you should continue or even increase the dose. And this is the PRISM trial which showed discontinuation has detrimental effects. And same thing, you discontinue statin, the hazard ratio increases irrespective of the type of MI. Besides the beneficial effects of statin, another effect which is not commonly recognized is that statins decrease the thrombogenicity of blood. And in the event of a plaque rupture, the probability of conversion into acute coronary event may be minimized because thrombogenicity plays an important role. Only 1 out of 10 plaque rupture culminates in. Statins, all of us know, has limitations. I'm not going to repeat. And this is the wonder molecule which we are talking of. PCSK9 is a protein which is secreted by the liver cells, and it comes to the surface of the liver cells, as you can see. Now, LDL is cleared by the LDL receptors, and LDL receptor is the only pathway for clearing LDL from the blood. And if you have increased activity of PCSK9, this combines with the receptors, take the receptor inside the cells, produces lysosomal degradation, and LDL receptors cannot be recycled and LDL increases. But if you block the PCSK9 with monoclonal antibodies, the receptors continue to cycle and LDL is decreased. Now, 3 molecules are in the late stage of development in the PCSK9 inhibitors. This is the first molecule, evolocumab, has already been approved, and it was tried in several trials, and many trials have been completed. Evolocumab already approved. This is tried in the Odyssey Global program, several trials, many of them been completed. And this is the bocuzumab, which is being tried in these 2 outcome trials. What are the achievements of PCSK9? LDL reduced by 40 to 60%. Another big achievement is LPA reduced by almost 50%, which is indeed very gratifying. And this may prove to be a boon for those high-risk patients where LDL goals are not achieved by statins, statin intolerance, and familial hyperlipidemia. Side effects are minor, and PCSK9 has started the dawn of a new era. And there's a lot of excitement, but the final word will be written by these 3 outcome trials, which are ongoing and to be released in somewhere 2017 and 18. Inflammation plays an important role in dyslipidemia and atherosclerosis, as evidenced by increase in the markers of inflammation. On PET-CT, you see the inflamed plaques. The LPA-PLA2 levels are increased, and it is concentrated at the site of plaque rupture. But statins decrease CRP, but attempts to use these inhibitors of LPPLA2 despite a sound theoretical basis, all trials with LPPLA2 have been negative, so the molecule is not being processed further at the present. And lastly, I will passing remark to 2 new agents for familial hypertension, lomitepide. You can see it is an MTTP inhibitor and decreases LDL cholesterol by 50% on top of statins and apheresis. And this is the mepomarsen, decreases LDL by 25%. So what is the take-home message? We have witnessed the statin era for last 25 years and seen so many benefits, and now the legacy effect also. The PCSK9 era has begun, and this is very important because now we have a pan approach to LDL control. What is this pan approach? We can reduce the intake of cholesterol by dietetic restriction. We can decrease the absorption of cholesterol by using ezetimibe. We can decrease synthesis of statins in the liver by statins. And this portion, which was totally blank, that is clearance of LDL from the blood, now we are empowered with these PCSK9 inhibitors. So LDL can be reduced to very low levels, almost up to 25, and we have seen it produces beneficial effect without any harmful effects. So the future seems to be bright for PCSK9 inhibitors, and we may be moving for another revolutionary era after 25 years for these wonderful molecules. Thank you very much.
Thank you very much, Professor Manoria. Ladies and gentlemen, we have 2 minutes for the discussion if the chairman would like to make any observations. In the present.
Dr. Manoria, you have very rightly brought out and pointed out this development of PCSK9. FDA has approved it even before the trials are completed, because in very severe in familial dyslipidemias. I want you to tell the audience, because they are mostly primary care physicians, it is a fact that statins are required in the prevention, and we are dealing with the prevention program. A person give the statins, the people start stopping it because they are having aches and pains. How do you practically go about it? Is the CPK, how much CPK is accepted? So that
if a person on statin has persistent muscle aches and his CPK is more than 10 times, this is a sign of statin toxicity. But before declaring it, you must take 2 things in consideration. One, vitamin D deficiency If it is present, it can produce muscle pains without statin toxicity. So we always measure vitamin D levels and prescribe it. Second is you have mixed edema. This is again a very common cause of muscle pains and a very common cause of dyslipidemia. What you are thinking is dyslipidemia is actually maybe. So these two things must be excluded. Then you can switch on to less powerful statins, and we have data that if you switch statins to alternate days, every third day, even twice a day, they may be helpful, although you don't have outcome data on these strategies, but the cholesterol is controlled to a great extent. PCSK9 are only meant to be used on top of statins in high risk where the LDL goals are not achieved. They may be a boon for statin intolerance, the real statin intolerance, where CKMB is elevated more than 10 times, not just muscle NX. And of course, for familial hyperlipidemia, besides statins, FRSs, the two new drugs, LDL goals are still not achieved, they may be put to that. So that is the role of PCSK9. It will never be used, at least at the present state of time, for first therapy. Statin are first, all comes next.
Thank you. Thank you very much, Professor Manoria.
Up to three times rise of CPK, you can...
10 times.
10 times
SGOT
toxicity.
is 3 times for liver, which we do not monitor. 10
10
times.
times is toxicity, but 3 times you can continue.
Less than 10 times you can continue, may decrease the dose, but the real toxicity of muscle damage is 10 times.
Okay. Thank you. Thank you very much, Professor Manoria.